So, sir, it's 3, 2, 1. We are live to the audience. Over to you, sir.
Thank you. A very good evening to all of you. It's my privilege and honor to be part of this forum. As we can see, we are here to cascade the new reflections and new learnings from IDF. So this program is entitled as Key Reflections from IDF. Reflections on the sense that some of the perspectives which are differentiating with respect to IDF, hypothesis generating, way forward perspective which are emerging from IDF, one of the strongest platform in this on this planet Earth in terms of bringing up new perspective, new directions. Key because it's a huge mammoth forum. We can only disseminate or instigate some new thoughts based on the very, very few key takeaways which can have a long-term reflections. So I welcome each one of you. We have with us, before we go any further, it's a sad day today that we lost Dr. Samuel Matthew, one of the known cardiologists in the country, eminent teachers of teachers. So we have with us Dr. Peter Schwartz with us, the known luminary. In fact, he has been one of the strongest face of IDF, what we know of in the history of IDF, and the strongest possible Indian connect. And we could see that his motivation each and every time in our country has been one of the biggest driving force that n number of clinicians were at IDF from India, strong representation from India. Thank you, sir, making us proud in terms of a stronger connect with the IDF, bringing the best of the world to India and taking some of the good elements attending the IDF at Bangkok. It has been a memorable, it will stay with us for a very, very long time. You don't deserve a formal introduction. Everyone knows you. You are the president of IDF, contributing immensely to the science of diabetes, and your philosophy has been so unique, not just the evidence-based. You instigate the people around you to bring up newer perspectives, unaddressed issues, population-based reflections, and also generating new hypotheses. We welcome you for this powerful deliberation, sir, and look forward for your impactful introductory comments and the guiding force for us for this program. Before I go any further, it's a proud moment. We have the leading thought leaders across the board. Very warm welcome to you, sir, Dr. Anoop Mishra, sir, leading light in the country. This is just one small symbolic reflection. We don't realize it at the hindsight that how well you have been contributing to the global dimension. These are not just a publication, it's a huge scientific legacy over decades of experiences translating into evidences. I think these are not easy tasks in our country, considering the fact we are limited resource, hardly any support for evidence-based, but I think the biggest motivation and inspiration is you keep documenting, we keep learning, keep writing more, sir, we keep learning more, as simple as that. Thank you, sir, for being there with us on this platform. We have with us Dr. Shashank Joshi, sir, with us, a known, eminent thought leader, brilliant exposition of science always, be it articulation, reflection, bringing the simplification of the science. That has been the strength of, sir, what we have seen for several decades. A very warm welcome to you, sir, and heartiest congratulations for your powerful reflections in the evidence-based medicine and making India proud consistently, sir. We have with us Dr. A.K. Singh. He is known as the brilliant king of trials. Dissection of the data set to the core. That's what he takes us in the depth of it. A very warm welcome to you, sir. Dr. Ganpati Bantwal is there with us, a leading light from the southern part of the country, brilliant exposition of science, sir. These are all some quick reflections, what you have been consistently contributing. A very warm welcome and heartiest congratulations, sir, for this prestigious forum, sir. And we keep looking forward to look and read more from your evidence-based perspective, sir, and making India into a different pedestal. A very warm welcome to Dr. Bipin Sethi, sir. He has been known for his pragmatic, practical, simple solution for diabetes management across the country, a leading light in terms of contributing to the impactful science of landmark clinical trials. Think of any landmark trials where India has contributed. Sir is always there to create a huge impact into the evidence-based perspectives. A very warm welcome to you, sir, for making us proud. And it's a moment for us that you are here with us for this prestigious forum. Before I hand over to Dr. Peter Schwarz for his introductory comments, I would like to proudly reflect that, in fact, sir, your contributions, the journey begins from 2025 from an evidence-based perspective. And some of the newer data sets which have been so prominently reflected that I was just curious enough to know that how well IDF is contributing into the journey of evidences. Way back from 1952, when the first Congress happened, in fact, in 52, there was a series of publications, 7 publications, which did the scientific coverage. Evidence started from there, from Amsterdam first meeting. And now we know that the flurry of evidences, consistency of it, reflects from a high impact factor journal. This is work in progress. This is a very primitive way of looking things, but a proud moment that IDF is contributing hugely into the evidence-based perspective. These are all the publications where the title of the publications contains the word International Diabetes Federation, not even IDF. So over to Dr. Peter Schwarz for his introductory comments and his thoughts about that, how this IDF has been and what will be the guidance for us. Over to you, sir.
Yeah, Dr. Navneet Wadhwa, thank you very much. It makes my heart very warm to hear this introduction from your side about the International Diabetes Federation and about what the International Diabetes Federation stands for. I would like to share my slides, and I cannot because in the moment it is still blocked. And now it works, yes. So thank you very much for this kind introduction, especially that you say that the International Diabetes Federation is back. And if you look into the publications, the big bars for the publication was in 2006, 2007. This was after the new criteria about how to diagnose metabolic syndrome was released. And if you are looking into the future, over the next 2 years during my presidencyship, we will address some of the key issues related to diabetes. So one, which is very relevant in Southeast Asia, in your region, is the type 5 diabetes. Yeah, I didn't make a mistake. I mean type 5 diabetes. This is a new kind of diabetes. In the past was described as malnutrition-related diabetes, but it's more complex than only this. And we last week we founded a group which will address the diagnostic criteria, how to diagnose, how to treat, how to prevent type 5 diabetes. And there are 34 million people living with this kind of diabetes, especially in Southeast Asia and Africa. But we also started a group about fasting in diabetes. We started a group about newly or harmonizing the diagnostic criteria about diabetes mellitus. And we started a group harmonizing the criteria for gestational diabetes. So step by step, more and more is coming from the International Diabetes Federation. We will work very closely together with the American Diabetes Association and the European Association for the Study of Diabetes and WHO. So it's a kind of, I will not say the new century of the International Diabetes Federation, but there is a new spirit. And this is what we have felt in the Congress in Bangkok last week. The people are passionate about improving the quality of diabetes care. The people are interested. They are discussing. There are controversies, but discussing different opinions, different positions, at the end drives us forward and gives us a chance to learn and to become together better than any one of us alone. So thank you very much to Dr. Navneet Wadhwa. Thank you very much to any one of you. A warm welcome to you. And I would like to share a few ideas in 1 minute about my ideas going ahead as president of the International Diabetes Federation. We are 75 years old now, and I will start a process now to bring a lot of expertise, also from India, together to build the organizations in a strong organization that we are also present in 25 years, so IDF 100 from now. And this is one example where we will learn from the Indian organizations. As president of IDF, I want to be in the brain of every politician in the world. I want to be in the pocket of every patient and in the heart of every healthcare professional. How to reach this? We will develop a global diabetes index. And this index will come from you. We will ask every year 100,000 patients and physicians covering all countries in the world about their perception of the quality of diabetes care. And we will translate this into an index and release the information regarding the index for free 3 weeks ahead of World Diabetes Day. And this should build a momentum to politicians to think about what they can do to improve the quality of care in their countries. Secondly, I'm dreaming that the International Diabetes Federation is in the pocket of every diabetes patient. So using smart technology, using YouTube, Google, Meta, Alphabets to deliver a freely accessible diabetes education to the smartphone of the patient in Congo who has no access to a qualified diabetologist or endocrinologist or a community health center experience in diabetes care. I know that using smartphones, we will not reach everyone, but we will reach many, many more than we are reaching today. And thirdly, to be in the heart of every healthcare professional. And this is you. You are listening here. The fellowship program of the International Diabetes Federation is one way to join a community of colleagues who are passionate about improving the quality of diabetes care. And in return, getting all the educational activities from the IDF School of Diabetes for free to train evidence-based all the colleagues worldwide to perform high quality of diabetes care. This is what IDF 75 stands for. And maybe this can stimulate us to write 75 position paper together, to invite new member organizations, start new projects, invite healthcare professionals as fellows of the International Diabetes Federation, individual membership, and find young leaders in diabetes care, young leaders who drive this field forward. If you find this QR codes here and you have your smartphone in your hand, use the QR code. It's always the same QR code to scan it. This is a channel where I invite everyone to participate and inform about IDF-related projects through WhatsApp. This is the shortest way to keep contact with me, and I'm looking forward to get any feedback, any comments, any ideas from your personal side, how to rebuild IDF into an organization where we say we are proud to be member of the International Diabetes Federation. A lot of faces of people living with diabetes. Let's work to put a smile on these faces of people living with diabetes. Let's work together with our ideas, our intuition, to finally help the people to walk away from undiagnosed diabetes, mistreated diabetes, wrong-treated diabetes, to improving the quality of diabetes care. I thank you a lot for your commitment, your energy, your passion, your commitment to build a community of passionate colleagues to improve the quality of diabetes care. But especially, I thank you for your action. Thank you very much. Thank you, Dr. Navid Vatwa, for organizing this, and I'm looking forward to the summary.
So nice as well, sir. Powerful, inspirational, motivational, energetic. That's a beauty of your deliberation and IDF reflection, so nicely reflected. So let me continue ahead in alignment with what you have reflected so clearly. Welcome, Dr. Shashank Joshi, sir. Welcome, Dr. A.K. Singh, sir. Just for everyone, while you were joining, Dr. Shashank Joshi, sir, expertise contributing globally into the multifaceted dimension of evidence-based perspective. Dr. A.K. Singh, you have been termed rightly as the king of clinical trials, dissecting the data set to its depth of it. A very warm welcome to you, sir, for this prestigious forum. And we keep learning in detail when you write. Keep writing more, we keep learning more, sir. Welcome to this forum, sir. So, important perspective from my own curiosity when I was exploring that where does the IDF as a publication index, the title publications. So this was the first, in 52, there were 7 publications which covered the entire Congress. The journey started, evidence-based perspective started way back in 1950s. Beautifully, some of the well-cited reflections in science. This was a beautiful lecture, what I could capture. I could make out, if we put ourselves in the historical perspective, the Minkowski Award lecture in 73, which described the beta cells to the possible depth of it. One of the rare articles which carries so many details as far as the images of beta cell dissection is concerned. That was an historical era wherein the beta cell centric approach was so strongly dominated. And look now, where are we in the non-beta cell alignment as far as beta cell sparing functions, therapeutics. So journey has come a long way on that perspective. Dr. Shashank Joshi delivered this perspective at IDF 2025. Can diabetes epidemic in Asia be prevented in the near future? Sir, I think it was a tough debate wherein you highlighted important arenas that with a strong message that comprehensive, scalable, sustained interventions are essential, overcoming systemic barriers to curbing the diabetic epidemic in Asia. Not an easy task, but policy framework, multifaceted approaches which are desirable and is to be looked upon. And from a perspective of Dr. Anjana Mohan's famous paper, that role of lifestyle factors. We all know this, but a good way of documenting. We are into the era, already into the era which have drifted toward the nutrition transition, shifted towards refined grains, high-fat food, sugar beverages, so and so forth, decline in fruit and vegetable intake, so many other reflections which are already there. So the drift already has been attributed strongly, unhealthy diets contributing to the rapid rise. So something known, but well documented from our own reflections, that the challenges and the reasons for the contributing elements for the reflections in science beautifully reflected that how the urban and the rural transition is happening, the differentiation between the rural and the dietary patterns, how different they are, and how similar versus dissimilar they are in terms of rural population consuming more cereals and less fats. However, in both settings, majority of calorific intake contributes to the carbohydrate. We are a carbohydrate-rich nation. The message is being reinforced from that perspective. Feasibility of prevention. How long, how far, itself is a question. But Dr. A. Ramachandran has contributed immensely from Indian perspective, which was being deliberated immensely. So we need a different solution, dedicated solution to the problematic statements. We are a different nation. So let us have a panel discussion, quick reflections from your thoughts. So key barriers to implement the scalable lifestyle intervention. The noise level is high, but how far, how long it can go in terms of prevention, categorically prevention. We are not a nation which is sensitive to this, but prevention, how well, how far, challenges, way forward with respect to the community being engaged, population being engaged at a much larger scale. Is it happening? How well it could go? Over to each one of you for your. We can begin with the South first. Dr. Bipin Sethi, sir. Sir, your reflections on this, sir.
Thank you, Navneet. It was nice hearing about what IDF has in store. To me, IDF has always been different from other organizations because it is more representative. It is not centric to the Western world. It incorporates and encompasses the difficulties faced by other countries and not just, and probably I would go a step further saying that it is more of a voice of developing underdeveloped countries, and therefore a statement coming from that organization is truly, truly welcome. And the engagement that this organization has had is always free of cost because they know the problems associated with access. The lecture that you alluded to was the most interesting lecture that I have heard in the past few years. As we keep talking about prevention, and the prevention cannot be done at a single level. And the President's remarks in this are most welcome, which state that it requires all stakeholders, be it politicians, be it the drug manufacturers, be it the public or the healthcare professionals. And I feel that this movement has to come from all levels so that we can take preventive measures. It's not enough for Dr. Shank or Anup or any of us to say that diet and exercise are important. I mean, that is something very important and everybody knows this. But how to implement this? how to create awareness, how to create pathways which lead to a sustainable momentum regarding these two efforts of healthy eating and getting food at the prices that people can afford and yet be healthy and also have healthful patterns. So I think it's involvement at all levels which is going to lead us there. And I think he's been very optimistic that it is doable, but the effort required is huge. So these two are things that I understood, and I'm convinced that if there is movement at all levels, then it can be achieved. Movement at healthcare professional alone, politicians alone, or public alone will not succeed. We require a lot of noise created in these areas, and beginning has to be done at some time. I think now is the time to do that.
Wonderful, wonderful, sir, wonderful. So nice. Any other perspectives, sir? Dr. Anup Mishra, your viewpoints, sir, Dr. Anup Mishra, because you have been contributing immensely into this science.
Sir, you are on mute.
Yeah. Navneet, is a very difficult question. We have been trying to answer for 2 decades with no headways. And things are escalating, things are not at all, not even plateauing at this point of time. I remember 1997, we were called to Health Ministry to make the first National Diabetes Control Program. After that version of a control program, which was submitted to the health minister, there were 3 more versions which were prepared, and some were implemented. And National Diabetes Control Program guidelines are very well there in the on the web, but the ground level implementation is the major problem. It began well, it ran for up to a certain distance, and then somehow it has petered down. Now, if you look at from one person's perspective, say, I do not know about diabetes or about exercise or diet. So I have to be told, number one. So awareness needs to be created more. And fortunately, because of media these days, there's more awareness. But still, I think much more needs to be done. Once you tell me that here is a disease, if you have a disease, it may have a problem, create a problem in next 5 to 10 years. And that these things, diet, exercise, proper treatment, engagement with your physician can prevent these problems occurring. I may listen or I may not listen. If I listen, what do? I go to the shop. I find the vegetables are too costly. I don't mind, buy vegetable. I buy some food which is quick and which is full of carbohydrate. So there, some interventions are needed. Then I try to go for a walk. I find that streets you cannot walk, that it's full of pollution. There is no green spaces anywhere. So see the complexity of problem. And once I was there for National Diabetes Control Program, it was suggested that 7 ministries representative must come and coordinate this program. And that includes the information about costing for engagement of reviewers, for messages, the urban, landscape ministry, the oil, food ministry, so many things. So that has remained a dream at this point of time. I don't know how much acceleration can be put there. Somebody with a deep political commitment, and I am very happy that some amount of acceleration has been given by our honorable Prime Minister, talking about obesity and oils and fat and things like that. And I was and Shashank also was called upon by Dr. Paul from the Niti Aayog to disseminate some messages, which we did. So something like this is needed. Something more is needed. And it's admittedly a very difficult problem, but can be done.
Thank you, sir. These are like truly professors' viewpoints. The top view policy framework. I think that's the big message, and I think it's a paradox for us as a nation when we are on the digital divide. One side, we look forward in terms of digital apps, some evidence-based perspectives, managing diabetes, patient empowerment programs. Other side of it, the food delivery apps. The food habits getting bad to worse at times. At the same time, technology, we cannot live with technology, we cannot live without as well. So in fact, this is the thin divide as far as diabetes is concerned as well. And the policy framework, that what matters. That's the big message which comes from you, sir. Thank you, sir. Thank you for that implications. Dr. A.K. Singh, sir, Dr. Shashank Joshi, sir, your viewpoints on this, sir.
So let me just highlight three things. One is that, first of all, I'm thankful that Peter allowed me to speak on this topic. He heard me and Mohammed debating this topic at DRS Congress in Mumbai. And he thought it will be apt, and this was a very well-attended debate in the IDF Congress. The biggest problem is implementation of a prevention program. We have sufficient evidence that it works. And I agree and echo the sentiments of Dr. Anup Mishra that so we need both the sides of the pyramid, from the lowest rung and from the top. So our Prime Minister is very committed to make a change. That's no question asked about it. Unfortunately, the implementation is not happening. So there are three challenges we have. First challenge is it has to be a mass movement or a Jan Andolan. Second is it has to come from the woman of the house because food is cooked by the woman of the house. Third is that it has to have set interventional points. For example, the school canteens and the workplace canteens. These are focused targets of intervention where we can do an intervention. And finally, the Fit India movement, in which we have to promote physical activity. So we have to take very constructive, meaningful steps for our nation because obesity and diabetes will bankrupt our nation. We are very clearly committed for prevention. Prevention is better than cure. We recognize it. Professor Schwartz himself, much before he got into IDF, we know him as a world expert in prevention. And we have known him for the last 2 decades personally. So very clearly from Dresden, he has been echoing this entire prevention movement. And we have to use simple ideas which don't demand effort and cost and make them scalable. There is no point of having a solution which is not scalable. So from the remotest village to the most affluent person, they should be able to adapt to the tips we give. Because ultimately, when we go back to eat food, we will eat exactly what we want. And therefore, the participation of the woman of the house is also equally important. So Jan Andolan, which is mass movement, which Government of India is very committed under the Prime Minister's leadership of Narendra Modi. And second is Nari Shakti, which is empowering the woman. These are the two important tenets in our current national program, but we have a long way to go. And we can't say it is government job. NGO cannot say that it is our job. It is all of us which has to get together. That is all. But I think I'm grateful that it's our IDF. We are all committed to work for it. And IDF is there in every village across the planet Earth. And we are one world, one village. And therefore, we should keep this momentum, which started at Bangkok, to reach the remotest corners of India through our physician brothers and sisters who are listening to this program. Please take up on yourself as IDF global brand ambassadors for a prevention movement. And Peter is a digital diabetes person of planet Earth. He will ensure that diabetes is in everybody's pocket. And I think it is there in the mobile of everybody. And I'm sure that this is the way to go. So thank you very much for the opportunity.
Wonderful, sir. And it has been a powerful deliberation, not just here, but as well at IDF. Powerful, as always, sir. Thank you, sir. Thank you for this. Dr. A.K. Singh, sir, your quick word on this, sir. Prevention, how challenging it is.
So I fully agree. I don't want to waste time further on this topic because starting from Peter to Dr. Misra, Dr. Sasank, everyone emphasized the importance of lifestyle modification. The point which we are discussing day in and day out is how to put it into practice. So as everyone said, if the administration wants it, you can do it. If I would have been the health minister of this country, the initial 2 sessions in every school and colleges would have been a PT session. Your attendance would be mandatory during the PT sessions. We are running for all classes, even if make a curriculum in MBBS course that every medical student has to appear in, exercise classes, without which you can't get the attendance, the entire landscape will change. But we are running behind going to anatomy, physiology class rather than, and if you look at even in a school curriculum, although you have got a PT classes there, nobody attends there. There, everybody is roaming around canteens and taking all those pakoras and everything, high calorie food during the PT class. It's not mandatory. So therefore, from the apex, from the all authorities, those who are at the helm of affairs, has to take care in implementing what we are always trying to preach. It has to be there on the surface.
Wonderful, pragmatic. With the due permission of Dr. Peter Schwarz, let me move ahead, sir. So weight management in type 2 diabetes, how to deliver in low income setting. This was a concise reflection from Dr. Anup Mishra, sir, at the recent IDF. So technology, quantification of exercise, some landmark evidences like direct trial. So there has been a flurry of evidence-based perspective, especially when it comes to our own setting, challenges, what it entails, the focus, what it needs. So leveraging the community-based platform for education and support, tailored intervention to fit the local context. This looks to be tall words. I think it's equally more difficult to implement at the large scale in a diversified nation like us. Quick comment, sir, Dr. Anup Mishra, sir, your viewpoints. How challenging is to, the keyword here is delivering sustainable weight management. It's not just a weight management, the durability of the weight management from a patient perspective in our own country, limited resources. Over to you, sir.
Thank you, Namneet. This was indeed my topic in the idea, and I did the best job of it, but I don't think whatever I did is good enough in the current scenario uh, because it is extremely challenging. This is the population, low income setting that we are talking about is the most unaware or poorly compliant population. So the first thing, which is also challenging for physician, is to spend a lot more time educating these patients regarding diet, exercise. And if they do proper diet and exercise, and I talked about a high protein, low carbohydrate diet, which we tried and published the data. A vegetarian high protein diet. It's very difficult to have high protein diet in a vegetarian population. And I compared also the approximately money spent per month in the high protein, low carbohydrate diet versus the keto diet, and there was a almost 60% more costly to have keto diet. So it is possible to have a low cost weight reducing diet, and also one can increase exercise to more than 300 minutes per week. Again, the question comes, where do you exercise? But fortunately, and I showed some of the pictures of the open gyms which have been present now in several localities of New Delhi. And people who cannot afford the gym go there. I also talked about the low cost therapy, and metformin, though it's not a weight loss drug, but still does something and should be used, of course, to the maximum doses. And generic SGLT2 inhibitors, which are available, can also be afforded in the low cost setting. Now, there are other drugs like liraglutide, which have come in the Indian market, which are generic, and though still it is quite expensive. So, like I said in the beginning, it is extremely challenging to affect a sizable amount of weight loss in this population, which is largely unaware of benefits of weight loss and benefits of looking at diabetes management. Still, with the low cost approaches, which I outlined, it can be done. There is hope for them.
Perfect, sir. Well said. Reinforcement of what you delivered at IDF, sir. Very nice. So let me just run through the type 5 diabetes. This is something what this current recent most IDF would be remembered for a long point of view, that recognition the malnutrition related diabetes as a distinct entity and primarily affecting the lean adolescents, so on and so forth. Huge number of patient population being implicated, and it's categorically not driven by insulin resistance as a differentiating element. So historically, reinforcing the current context becomes important. So very pertinently, clinical features being well described, ascribed, and also there has been some work from India itself with respect to Vellore declaration, emphasizing on the need to address these issues. So type 5 diabetes needs better diagnosis, tailored treatment, resource allocation for probably, I'm using the word cautiously, the word probably, historically neglected population, and we can look forward into the guidelines and the dimensions coming through. Dr. Peter Schwartz, sir, your quick comment, if any, on this current and the futuristic perspectives on
I
this.
think the most important word you have used was neglected population, because
Yes.
in January we had the Vellore consensus meeting in Vellore where the declaration came off, and I was invited there. And I must say, I was shocked by recognizing that in 1999 and 1998, there was a consensus meeting about malnutrition-related diabetes, and the expert couldn't find a consensus. So the WHO, who already had this kind of diabetes on its list, took it off because they said the experts don't find a consensus. And we had about 48 colleagues from all over the world in the room. And the number of people affected by this kind of diabetes is about 34 million, mainly Southeast Asia and Africa. So neglecting 34 million people with a kind of diabetes, this is wrong. And this is where we have to act. And this is where the International Diabetes Federation took action. And I installed this group led by Meredith Hawkins and Neil Thomas. So we have a good balance between Indian expertise and the US expertise. And over the next 2 years, they will write down a guideline what is this kind of diabetes? What is the pathophysiology? Because the patients are manifesting with high A1C, but they don't need insulin. They are well treated with metformin. And the background of this disease will be described. And it is maybe malnutrition related, but not of the patient himself, of the mother during pregnancy, who had a low protein content, and by this the baby or the offspring has less beta cells developed. And but this is a hypothesis in the moment. They will put this together and recommendation for how to treat and prevent this disease. And I think this can become a very, very important step forward for providing better care for people living with diabetes. And this is what is driving me. If there are neglected 34 million people with this kind of a disease, we have to name it, we have to describe, put the evidence together and describe how to diagnose and to treat. And this is what is this group about.
Thank you, sir. And this will way forward. This will be the way forward for futuristic research as well. Recognition, the first driver. Dr. Shashank Joshi, sir. Sir, your thoughts on this?
So I think I have to congratulate Professor Peter Schwartz and Nihal for two things. I have to give a little historical context. My journey with IDF started in 1997 at IDF in Helsinki. The International Diabetes Federation's first meeting, which in my life I attended was, and my paper was MRDM tropical pancreatitis from Western India. That was my first paper at IDF. This is my history. And my mentor was Professor C.S. Pichumani. He's a world top 5 experts in pancreas in the world, who I worked in New York. And he was a student when I was born in 1967 of Professor P.J. Ghee-Varghese. And Professor P.J. Ghee-Varghese and Dr. Pichumani worked on an entity called FCPD, fibrocalcific pancreatic diabetes, which was the first one form. And that time it was popularly called as Kerala diabetes. And that was due to the cassava plantations, malnutrition, and the deaminization of the liver, detoxification was not occurring. So cyanogenic alkaloids were going and getting into the pancreas. We developed the entire hypothesis and model on this Kerala model of FCPD.
Yes.
And now we see it across the world. People labeled it as a secondary diabetes, but it's a very well documented variant of FCPD, which is an MRDM.
Yes.
The second one is the lean type 2 diabetes, which was protein deficient diabetes of late Professor Tripathi BB, who spent his lifetime working on this. He's one of the founders of RSSDI, who we all know. And this was researched in Orissa. So it was called as Orissa diabetes and Kerala diabetes. And that was the hypothesis. But this was not on global footprints. So Professor Anup Mishra's teacher, who was a first president of IDF from India, Professor J.S. Bajaj, who did the meeting of IDF in India in 1975, he coined the term MRDM. So there's a lot of history to it, and I'm sure Professor Anup Mishra will add to that entire Professor Bajaj story, because he does the Bajaj Ahuja Symposium. He's the direct student of Professor Bajaj. My mentor, who's again no more, Dr. R.D. Lele, also described very elegantly what Dr. Bajaj and Dr. Lele both wrote an article in the Diabetic Association of India with Dr. Boraskar and Dr. Raheja, that this entity does exist. Unfortunately, the Western world criticized us and they threw us out on the bucket that this is just a variant of secondary diabetes. But it was a very distinct entity.
Yes.
WHO labeled it and removed it as a secondary form of diabetes. I'm very grateful to Peter. I never had the opportunity to talk to Peter at length. I'm going to send him all the materials of the last 25, 30, 40 years. I'm going to connect with Professor Pichumani, who is now 90 years plus old, lives in New Jersey, who has worked on this subject. Professor Mishra has publications in this area. There are people like Dr. Nageshwar Reddy in India, who is a gastroenterologist who has worked in this area. And this area needs a lot of delineation and deliberation. I'm happy it has started. We have all worked in this area, and we'll share all our data and publications with Peter and his group so that this takes up the next shape. Unfortunately, what happens is we have also a lean variant of type 2 diabetes, which is seen in hilly regions of India and remote rural areas of India. And they have a BMI below 19 or 18. And we also see that in our practice. So this is an area to be investigated, and it is a subform of a cluster. So type 5 diabetes is a cluster. So then we have type 1, then we have 1.5, which is LADA, then we have 2, which we all know, then we have 3, which potentially has a Alzheimer insulin resistance of the brain. We have 4, which is possibly GDM, and we have 5, which is possibly a variant of malnutrition, which is being now crystallized in a little more segmented. And in the 5, we can have different subtypes, the FCPD subtype, which is the pancreatic subtype. We can have a subtype of lean. And I will send actually I have a whole presentation on this. And I'm going to share it with Dr. Peter Schwartz, because we are here to learn and share. And therefore, that is the whole exercise. And I'm sure Professor Mishra also is very erudite in this entire domain. And it's time, Dr. Mishra, that we should both write up something on this subject. And we take all domain experts in the country who have worked in the past, like Dr. Pichumani and many others who have been contributing in this subject, and probably write a historical overview of this entire journey from Bajaj, late Dr. Bajaj, late Dr. Lele, late Dr. Ahuja, late Dr. Tripathi. There used to be Dr. K.C. Samal from Orissa who used to work in this subject. Dr. Siddharth Das wrote a whole monogram on in 2002 on lean onset type 2 diabetes. And I'm happy that Meredith Hawkins and Nihal restarted this debate. Of course, we wrote a letter to that also, that this particular type they have described, it may be a variant of lean, needs more exploration, but the Orissa variant, the Kerala variant, the FCPD variant has been forgotten. And Dr. Bajaj actually had coined a new term for it. And I'm sure I'm not going to steal the thunder from Anup. He will allude to it. I'm sure I can see his hand up. I didn't have an opportunity at IDF because we were all kept very busy by our friend Dr. Peter Schwartz. So we couldn't really deliberate on the science part of it. But I'm happy that you opened this Pandora's box. And Peter, thank you so much for restarting this debate. Because of conjunctivitis, I couldn't travel to Vellore. I had an eye conjunctivitis, if you remember. And therefore, I couldn't travel to Vellore. I did my meeting virtually. But I'm grateful that at least this process has started. And there are 2 years for us to exchange ideas, exchange the old research notes and publications so that it's put in a more granular format. Anup?
Wonderful, sir. Over to Dr. Anup Mishra, sir. In fact, before Dr. Anup Mishra, comes up. I remember 70s was an era where Dr. Shashank Joshi's publications are well documented. Dr. Anup Mishra, sir. Sorry, 70s and 80s. In fact, I remember some of it. Yeah.
Thank you, Shashank, for giving me that whole perspective. I'll be very brief. Dr. Bajaj was my mentor, and he, along with others, as Shashank has mentioned, was instrumental in getting this into international platform. So somebody sent me, this is a new type of diabetes. I said, this is 50-year-old. And when I was undergraduate, we were being taught about it by Professor Bajaj and Professor Ahuja. In the post-graduation, we all had to do some thesis. And my colleague, Dr. Rakesh Shagwal, who's a neurologist now, did his experiments on malnutrition of monkeys. And so Dr. Bajaj had experimental model of malnutrition in the monkeys, and he showed that the beta cells were down or impaired functioning of beta cell after the malnutrition was induced. So he had experimental model of it. At some point of time, when he was IDF president, he wrote article in the book which was used to be published at that time, and he wrote this particular condition as Bajaj syndrome. So that was the importance of Indian contribution to this particular type of diabetes. Of course, as yet, still things are not very clear. It needs a whole lot of research before actually categorizing clearly this as another subvariety of diabetes. So it's good that it has got prominence, but that means we should do more research into it and categorize it in a more detailed manner before we say that it is a definite different type of diabetes than type 2 or is just a variant of type 2 diabetes. So thank you, Navneet, for getting this into attention.
Perfect, sir. Thank you, sir. Dr. Peter Schwarz,
Dr. Navneet, maybe I can respond for 1 minute. I'm
of course
very, very thankful to what Shashank Joshi and Dr. Anup Misra just have mentioned. And it somehow represents the discussion which was in the room at the Velour meeting. And even if I fully understand that there's a lot of research needed before we can describe this kind of diabetes, on the other hand, I still would say we have to step ahead, because the big mistake 30 years ago was that the experts couldn't find a consensus and we neglected this kind of disease. And if we have the patient with this kind of diabetes in mind, and our colleagues don't find them, don't know how to treat it, or mistreat them because of missing classification, this is what was driving me that we have to step ahead. And the NIH and NIDDK, they are also very keen on supporting research in this field about type 5 diabetes. And I'm fully aware that this is needed, and the group will come up with unanswered research questions and which have to be answered by new studies. But on the other hand, I am committed to say we have to step ahead, we have to give it a name, and we have to help the colleagues in Congo, in Rwanda, in very rural areas who are not interested in research, that they can name the disease correctly and treat this patient correctly. This is where my heart is beating for. And I'm very, very happy that so much research and information is existing. But I was shocked that the experts 30 years ago couldn't find a consensus to name the disease in whatever way they want to name it. And this has WHO motivated to take it off of the list. And suddenly it didn't exist. And I think this was a big mistake. And this is what is driving me to step ahead. It doesn't mean that we neglect any work which was done in the past. It doesn't mean that we don't want to do more research, But I want to put the community together to say, okay, we are dedicated to elucidate this kind of diabetes, and everyone is very, very welcome to contribute. So thank you very much to
Wonderful,
these
sir. Wonderful.
ideas.
Neglect the first step by the virtue of ignorance has to be curtailed.
Yeah.
We wait for this atlas every time. We all know that this is the most powerful epidemiological reflections, no other document data set. There cannot be any diabetic meeting irrespective of the fact that if any epidemiological reflections, IDF atlas is the benchmark always, very clearly reflected, just published very recently as a comment that over 250 million people worldwide unaware. That is a key driver of the fact, and numbers are glaring. I'm not getting into details of that because this keeps up increasing each and every time. But this brings into the perspective that young, elderly, each one of is contributing immensely. We are living longer. Health span versus lifespan. Health span also is contributing into the immense number. That's a big message which comes from it. Indian landscape, dangerous implications, but I think of real powerful implications. It also shows the way forward, be it the economic burden, high rate of undiagnosed cases, projections getting on a higher tangent, major contributor of regional burden, significant at-risk population, high diabetes-related mortality, second highest type 1 diabetes burden as well. We generally ignore that from the complexity of it. So varied implications. So this is the beauty of this, that IDF Atlas, such a strong data set which comes from the Indian-centric approach, and also we are not getting into the methodology of the numbers. It's a very complex and a dedicated way of getting into these numbers, which IDF has been known for. Quick comment on this. Undiagnosed cases, simple and practical steps can be taken to improve early detection, support young patients, strengthen diabetes care across the country. Some of the points we have already discussed. We can have a quick comment on this. How do we overall, maybe the detection in young, the time bomb phenomena, what has to be addressed?
Navneet, please ask Dr. Singh and Dr. Bantwal.
Yes.
They haven't spoken much.
Yes. Dr. A.K. Singh, sir, if you're there, would love to hear it from you. Dr. Ganpati Bantwal, sir. Sir, any quick comment from your perspective? Dr. Shashank Joshi, sir, Dr. A.K. Singh, sir, Dr. Anup Mishra, sir, your quick word on this. Challenging, difficult.
It's very simple that we have to get patients or get people to come forward themselves to get tested. Instead of doing the mass screening program or testing which Government of India was doing, because it is not going to be cost effective in the same manner. So how do we encourage people to come forward? Number one, we tell them what are the risk factors. And somebody whose mother, father are diabetic, they are highly prone to develop diabetes, so they should come forward for testing. And many such people now are coming forward for testing themselves. Number two is importance of obesity. I think this is very, very important. That obesity is a problem, can increase blood sugar at a very young age, and abdominal obesity is a specific problem. And we have written a lot about it. We have recently revised the definition in the Lancet paper and also India's obesity definition recently.
Yes.
I think this should be disseminated a lot, because many of the people just starkly ask me, Doc, my weight has something to do with my sugar. And I'm amazed that these people are well-read people. They are not from low socioeconomic strata, and yet they don't know. So if we do it very aggressively, and like Shashank has said, in the advertisement audiovisual program, and we have done it earlier in the pulse polio program, we ran a successful national campaign. We can do the same again. And if people start coming, they started exercising because of it, we will have both prevention as well as early detection of undiagnosed diabetes.
Wonderful, sir. In fact, your Lancet reflections, obesity, counteracting that has been a powerful reflection. You dissected it so well. It's a well-known, well-cited paper now. Thank you for that, sir. IDF Atlas, we know that it has been a differentiating elements, elderly reflections being so clearly be reflected, the propensity, the way this is growing, clearly reflected. Unfortunately, we are in the leading map of that reflection. So we have already discussed this. Younger adults need a dedicated solution as well. Most critical clinical and public health challenge, as I might pointed out. Any quick sentence on this, not even a comment. Younger adults, how dangerous, where are we moving from your experiences? Considering the fact, sir, once you started your practice and now, where do you see that, proportionately numbers are increasing, maybe difficult or aggressive approach is required? How dangerous it is now? Yesteryears and now.
You're asking me, Navneet,
Yes, sir,
or
yes, sir.
Can you just abbreviate your question?
Sir, yesteryears, decades back and now, how the younger diabetics, are the numbers just growing or the form has changed in terms of aggression, the modalities which are needed to have an aggressive management?
I feel only the obesity is driving diabetes in younger population. Around 2 decades back, we did the first paper of obesity in teenagers and the type 2 diabetes occurring because of that. That was one of the first papers from the South Asia. And we clearly concluded that it is obesity that is driving diabetes in the younger population. And that's where we have to really strike at. So obesity is increasing the blood sugar, but the good part is if we decrease the weight, we can actually make the diabetes go away. So both ways, it is going up fast, it can come down fast also. And this is what we have to, I usually tell the patient that we can make your diabetes go away. You have to work on your diet and exercise, and we can give you certain drugs which can make you lose weight. And that is where the story will end for diabetes and may not come up if you do enough for the long term.
Wonderful, wonderful. Practical implications, challenging scenarios. Quick reflections. Newer agents, in fact, as a nation, I think we are the powerful consumer. If we look into the per milligram consumption, we must be the largest consumers of SGLT2, considering the cost, approach, accessibility, and the ease of it. Considering all those reflections, the data set also reflects that even the younger population, younger by definition, more than 10 years from a label indication. So the propensity, the dimensions of evidence-based medicines has evolved a lot. Dr. A.K. Singh, sir, your thoughts, how does these agents, newer agents in per se, access affordability, the agents which are affordable and accessible when it comes to SGLT2 DAPA, does it fit well? That especially, I'm not even using the word categorically, the young onset, maybe the early onset or the relatively lower gradient of age compared to the historical years. Sir, Dr. A.K. Singh, sir, your perspectives on this. How do we address this challenge under the ambit of the newer agents? Affordable newer agents.
Yeah, so that's a little bit tricky questions. We don't have too much options in, adolescent type 2 diabetes. I'm not talking about adults with type 2 diabetes and heart disease, heart failure, CKD, SGLT2 has a established indication, class 1 indication. There's no debate about that. But when it comes to young adolescent type 2 diabetes, we have a very limited options. Now, the good part is that, this SGLT2 has been found to be effective even in adolescent populations. As you know, there were 2 head-to-head trials done,
yes.
With SGLT2 compared to DPP4 inhibitor. So, as you know, the dapagliflozin has been approved in people who are more than 10 years old, based on one trial called Type 2 Now, where they compared dapagliflozin to sexagliptin. And interestingly, dapagliflozin was more effective than sexagliptin in adolescent type 2 diabetes, where their age was 10 to 25 years. There was another study called Dynamo study where empagliflozin was compared to linagliptin, 5 milligram in people who were 10 to 17 years of age, and empagliflozin was found to be effective, but not linagliptin. So what is interesting that the DPP4 inhibitor, which is considerably considered as a safe agent in elderly and also perhaps in younger population. It didn't work. Both sexagliptin and linagliptin failed in two randomized control trial, and surprisingly, both IMPA and DEPA were more effective and with a statistically significant HbA1c lowering, hovering from 0.8 to 1% in type 2 now and Dynamo study. So good to see that, we have got now newer tools, but then again with a catch that we have to really define that these are type 2 diabetes, young type 2 diabetes, and we are not dealing with type 1 diabetes. So we need to be mindful of the fact that these adolescent, people with type 2 diabetes is real type 2 diabetes, and they don't suffer from, type 1 diabetes by any means. And so that's a welcome step, tools we have for the young adult. We had nothing in the past. Everyone with young adult, you have to go to insulin. So now that's good to see that the GLT2 have come up and you have a license to use, both DEPA in adolescent more than 10 years of age.
So I think one powerful reflection which comes up, usually what we see when it comes to evergreening of patent, pediatric population comes at a much, much later stage. And in fact, so many molecules not being evaluated. We have seen in other therapeutic arenas as well, but beautifully, it has been done not so late, I would say. And you powerfully reflected, bringing out the perspective that adolescents, young, may deserve the limited options. One of them becomes this particular arena. Thank you, sir.
The study you are showing is the same type 2 now.
Yes,
right?
yes,
This is
yes,
type 2
yes.
now.
24 one. Yes, sir. Yes, sir.
Right.
Beautiful, sir. Thank you, sir. Dr. Shashank Joshi, sir, your viewpoints, your comments on this, sir.
I want to give you a little bit of history.
And
the previous IDF was held at Lisbon.
Yes, sir.
And for the clinical stream, I was the stream lead. And in that, Dr. Jonathan Straw, who was the program chair of that meeting, told me last minute that we have to insert one talk of 15 minutes, which was actually from Harvard. That lady presented the adolescent data of EMPA first time in the world, before it got published in New England Journal of Medicine, in the adolescent type 2 population. And you see, many times IDF is the first place where first time the data was published. I remember this very distinctly. And I think this is work in progress. These are novel agents. Both the GLP-1 receptor agents of proven efficacy, as very rightly AK has said, as well as SGLT2 inhibitors of proven efficacy, in this space merit more research and merit more data, because the longevity of young population with diabetes is going to be 30, 40, 50 years. And we really need to add live 2 years here. And therefore, if we have disease-modifying drugs, I call SGLT2 inhibitors as disease-modifying drugs, because they are going to make you live longer by making the cardiometabolic and renal profile better. And therefore, from that standpoint, there is a compelling need to generate more data in multi-ethnic populations across the world. And that is a need of the hour. And therefore, this is a welcome step, but it's still work in progress. And the level of evidence is still probably C or B, but it needs to go for a little higher hierarchy. And we still need, and therefore IDF is a very good platform, because where research is done, diabetes is scarce. And where diabetes is plenty, research is less. As Dr. Peter also alluding to, in those remote African nations, which is the next hub of the diabetes, it's going to be Africa. That's where it's going to explode. And DAPA is off-patent generic. EMPA is off-patent, it's generic. So we will have these disease-modifying agents for a larger population at an affordable cost. And that's really the need of the hour. And I think I would again urge Peter here to take this up, that affordable access of disease-modifying drugs can change the landscape of diabetes complications. And this is an important area to deliberate, dialogue, and discuss, and generate some science around. Thank you.
Beautifully alluded, sir. Disease-modifying reflection, sir. Well noted. At the same time, on the other extreme of age, well alluded, the data set are very clear that elderly population, the dynamics of it, we all know that, but it's a emerging burden. Earlier, we remember only the Japanese data set, elderly versus very elderly, used to be the benchmark population. It has been said that if we want to show positive results, enroll more and more Japanese population. Perhaps that may not be true now. So elderly, any specific quick concerns? And we have agents now. We all know that there are agents which are addressing multi-comorbid scenario. In fact, thanks to Dr. Steve Nissen, if that would not have been the case, the regulatory norms would not have changed, and we would not have seen the regulatory-driven approaches to design those clinical trials and seeing the reflections now. Any quick comments on this? That how do you view this as that newer agents? Does it help to address the unaddressed population, say 10 years back from now, which we could not address, and maybe the health span of the population being increased at the larger spectrum? Quick comments on this. Sir, Dr. A.K. Singh, sir.
Thank you, Navneet. So, yeah, you are alluding to one of the real world studies. SOLD is a real world study.
Yes,
so
yes.
that's a weaker evidence, but I can tell you from the randomized control trial, declared TIMI is a different example. Now we have got nearly data from all the cardiorenal heart failure trials of a SGLT2 inhibitor stratified on the age. What is interesting to note that despite that, we all are a little bit careful, or I would say pharmacovigilant, while prescribing a SGLT2 inhibitor in elderly population. But the data suggests that these are the population who benefit most with the SGLT2 inhibitor. For example, if you look at the DEPA heart failure trial, stratified on age, so less than 60, 65, 55 to 65, 65 to 75, more than 75. Actually, the quantum of benefit in the composite of heart failure, hospitalization, and cardiovascular death was larger in people, those who are elderly. Similar, things happened in the DELIVER trial with dapagliflozin in people with heart failure with preserved ejection fraction. When they were stratified on age, the people who were elderly seems to get the highest benefit. Now we have got many papers, those looked at the frailty, even not only elderly, but the frail, people with a frailty index of more than 0.2. So CKD is a different part. Even in the impact, kidney outcome trial, those who were elderly population had the larger quantum of benefit in the impact kidney outcome trial. Okay, so although their, P interactions were not significant, they were suggesting that the benefit happened regardless of the age. But if you look at the, absolute risk reduction stratified on the age, it is clearly appearing that these are the population who actually gets the highest benefit. So in one hand, we need to be a little bit careful while using a SGLT2 inhibitor in people, those who are elderly, so octogenarians, but also we need to remind that these are the people who gets the highest benefit. So these are the little bit balance we need to make in clinical practice while using these newer class of drug.
Wonderful, sir. In fact, very cohesively reflected on that front. Any other viewpoints, comments on this? Elderly as a differentiated approach from an epidemiological reflection. India getting towards that. We are an aging nation. Okay, let me quickly move ahead for the paucity of time. We'll just finish in few minutes. So again, a quick reflection. Undiagnosed. I think this is a ever-growing challenge. Unaddressed gap, diagnostics, screening, etc., huge reflections. A quick comment, sir. Dr. Anup Mishra, sir. Any thoughts on this?
Yeah,
I know it's a tough challenge.
I have very strong thoughts on this. And if I am somebody who can shape the policy of Indian health, then I will only put 90% of my money on primary health. If we have people in primary health center who educate the people, who get the people into some sort of a screening system, we can win this whole war. So primary health center, which encompass vast majority of our population, and the urban population, we can have secondary health center and tertiary who can help us. If we have the pyramid on the other side, on the top is the primary health, on the middle is the secondary, and in the bottom is the tertiary. The top is something that needs to be approached first and with full force and on the long-standing commitment. That is the problem. Commitment is the problem. Commitment is 6 months, 1 year, 2 years. Here is a disease which actually progresses over a decade or so. And so a task force, if made, should last a decade regardless of political changes in the regime and things like that, with a singular focus on primary prevention of this disease, then only we can achieve somewhere. Otherwise, we'll see another idea and we'll see another higher number of people from India and another idea, another higher number of people with diabetes from India. It is never ending story.
Yes, beautiful. Inverse pyramid approach, policy framework, thought processes. I'll quickly run through. Pre-diabetic population, I think this is always an emerging, ever-growing time bomb, which has been reflected. In fact, numbers ever-growing. Diagnostic versus undiagnosed may be a much larger scale. Pre-diabetic HbA1c range, practical strategies. What we need to address, maybe the fitting bus. If I was looking into the evidences, in fact, fortunately, affordable medications do address, but I think pre-diabetic needs a intervention at a much early stage, or for that means the pre-diabetic patients remain at the pre-diabetic for much longer span of time. Dr. A.K. Singh, sir, your viewpoints, is it the future to address this primordial versus therapeutic? India, what does it deserve? How well prevent, is it possible to have patients stay longer at pre-diabetic stage, or do we need early intervention from a pharmacotherapeutic approach?
Yeah. So that's a little bit tricky. So I don't encourage pharmacotherapy at first place.
Sir, I'm cutting you across. This reminds me of your metformin publication also very recently, which you brought it in a holistic way. If you can bring that up as well.
Yeah. So now we have enough evidence from several trials conducted in people with pre-diabetes, started from US DPP to Indian DPP to Chinese DPP, etc., etc. What we learned that the intensive lifestyle medication is the best. That beats heads-on metformin, starting from US DPP to any trial. So therefore, the lifestyle modification we started, Professor Peter started with the lifestyle and everything. That's the crux. Pharmacotherapy comes very, very late. Someone who can't do it, see, because of several issues, you might get, 150 kg weight person who can't move, who has got osteoarthritis, or for several reasons he can't walk. These may be the cases where pharmacotherapy's role comes into play. However, by and large, the role of lifestyle modification cannot be undermined in the pretext of any drug, be it metformin, be it SGLT2. The SGLT2, has got less data compared to metformin. So, these are very small mechanistic trials. We do have some evidence from DEPA heart failure trial and DEPA CKD trial that initially suggested that a SGLT2 inhibitor may have a potential to prevent new onset diabetes in people with pre-diabetes. And I did a meta-analysis, and which after the IMPA kidney, when we pulled the data from all the, SGLT2 trials together, there was 20% risk reduction in the, conversion to new onset diabetes. Having said that, this looks fine, but then, I still would be the last person to use any active pharmacological agent in people with pre-diabetes. Yes, once, lifestyle is, fails or you are not able to do it, then you add metformin, still you are not able to do it, maybe then the SGLT2 comes into picture. Even GLP-1 has got data. Look at the STEP trial results. The extension of a STEP 1 for 76 weeks reduced new onset diabetes by 70%. So, everything stands out to be somewhere, the reduction in weight. Even the SGLT2 contributed to the weight. Even if you look at the US DPP trial, the metformin benefit was seen in people who had lost highest weight in the metformin arm. So as Dr. Misra always said, that lose weight and wins everything. whether it is pre-diabetes or diabetes or obesity, the crux is the lifestyle modification.
Wonderful, wonderful. So in fact, that's always a benchmark. But unfortunately or fortunately, I don't know how to put it, as the ease of access to these drugs entails that on the counteracting force that lifestyle modification is the most difficult prescription. At first, it doesn't even come at the prescription level. If it comes, it's the most difficult prescription to be adhered. I think we should not fall back into the pharmacotherapeutic approaches offhand, but the challenging scenarios. Dr. Shashank Joshi, sir, your comments on this. Quick word on this, sir.
Lifestyle is supreme. All trials of prevention have shown that in pre-diabetes, 2/3 are prevented by lifestyle, 1/3 are prevented by metformin. But I think we don't have data on SGLT2. We had data from some data zone from India itself, which could go up to 50%. Troglytazone unfortunately moved out of the DPP program. One thing is very clear, that there is an urgent, compelling need to see the data coming out from tirzepatide, where they have given tirzepatide to obese people. And in that, there is a remission possible. And remission is the next buzzword. So remember that this is a space of where remission is doable and possible. So pre-diabetes, if it is aggressively, I personally feel we should hit early pre-diabetes and recognize it as a disease. That's the urgent plea to Peter, that if he recognizes pre-diabetes as a distinct entity, then people will aggressively treat it. And when they know that this is not just a condition before diabetes develops, but it's a serious disorder, it's a chronic metabolic condition.
Yes.
It is work in motion, and we need to hit early, then there is some possibility of urgent intensive lifestyle. So if you ask me, the answer is intensive lifestyle with or without drugs. And the data from tirzepatide in obesity actually shows remission.
Yeah.
And of course, that is not designed for it. And you will have some more data outcoming it. I'm sure AK, my good friend, will give you a little more data and insights into it. And many other molecules in this space will show similar data in the obesity space, because obesity is rapidly progressing and we will be able to prevent diabetes in the near future.
Wonderful, sir. Wonderful. Thank you, sir. This particular data set from IDF Atlas also reminds me, of course, maternal age and the risk of hyperglycemia has been reinforced very clearly on that. GDM perspectives emerging. And this also reminds me with the stronger connect. Yesterday, a beautiful publication in JAMA, which tells us the gradient, higher the gradient of BMI, greater the impact and the detrimental risk as far as pregnancy is concerned. So BMI becomes an important area which has got its own independent implication. Steep rising women over 30 reaching nearly 50% in the 40 to 49 age groups. So is it a challenge? Is it a harbinger of difficult arenas to manage GDM? Dr. Peter Schwarz, sir, your comment, because IDF is a strong proponent to address this now. Sir, kindly unmute, sir.
There are 19 different ways to diagnose hyperglycemia during pregnancy. And this is also an aspect, as I recognized this, I was shocked, because every one of us is doing diabetes care and diagnosing hyperglycemia during pregnancy in his environment. But we don't know how this is in the rest of the world. And having so many different ways of diagnosing hyperglycemia in pregnancy makes no sense. So the International Diabetes Federation will address this, not changing anything, but harmonizing the way how to diagnose gestational diabetes, hyperglycemia during pregnancy in a harmonized way. The main thing then is how to address the intervention. How early should be diagnosed? How early should be the intervention? When is the mother and the offspring benefiting from an early intervention?
Yes.
In some cases, this is unanswered. And I'm referring again to India, to Dr. Yannick, the only one in the world who has 3 generations tested with pregnancy and the offspring, pregnancy again, offspring and pregnancy again. And this elucidates some of the new aspects about the pathophysiology. And I think as scientists, we should be driven in developing standards of diagnosing a disease based on our pathophysiological understanding, and not on political instreams or reimbursement instreams. we should diagnose the disease in its early stages we can do. And I hope that the outcome of this working group will address this.
Yes. Thank you, sir. 30 seconds to close this meeting. We all know this complication arena, very distinctiveness from IDF. We're not getting into details of that. We all know that, but overall recommendations, one last slide. This has been the strongest possible reflection, but the cohesive reflection, which gives a very holistic picture, right from epidemiology, addressing immediate hyperglycemia, global program insights, implementation framework, so on and so forth. So considering the large population, I think if we implement IDF recommendations at large, it's not the Western world data. It's a cohesive global data set, taking into account so many factors which were unaddressed. Even if we try to replicate ADAs of the world or ACE of the world, it doesn't fit into our population. But I think this one single slide, perhaps I believe, fits in so well into the journey of perspective that how the deserving patients should gain more and more out of the entire holistic perspectives. Thank you, sir, for bringing this as a leading light, much needed from at least from India-centric approach, aligned well into the thought processes. So this is what we entailed. This meeting has been a harbinger to have a greener planet as well. We didn't realize in the era of multitasking in our own comfort zone, time management and making the planet greener. That has been the hidden perspectives as an outcome of this meeting. Of course, the virtual connect enables the science continues as a quick reflection. So this is all I had to share from my perspective. Quick feedback from the thought leaders about this meeting. Dr. Peter Schwarz, sir, your feedback about this meeting. 15 seconds to close.
This is exactly what we have to do, that we discuss science in its way to apply it to medical care, to the last mile of reaching patients living with diabetes. And this is a passion of the International Diabetes Federation. But I must say, the leadership in doing this, it's not with IDF, it's not with me as president of IDF, it's with all of you doing on a daily basis diabetes care, seeing the patient, deciding how to treat, how to diagnose, how to prevent. And this is the important work. So thank you very much for your leadership in improving the quality of care for your patients.
Honored, sir. Dr. Anup Mishra, sir, your quick feedback about this meeting, sir.
Thank you. First of all, you arranged the meeting very well and kept everybody, all of us engaged. My only thought is that while our government and our leaders and our doctors are doing the best possible, we are unable to contain the epidemic which is going on. And there's no point in talking about numbers now. We must do original studies to see our population where best can it benefit in a low-cost manner, in the best possible scenario that encompasses most of the population. That, innovative research projects have to be done. This is something which is lacking in our population. We have tried to do our bit. Yeah. AK has tried to do his bit. Shashank has tried to do his bit. But that's not enough. None of this is enough. None of this is enough. And there's so much to be done. Heterogeneity in type 2 diabetes, for example, so-called type 5 diabetes. There's so much to be done here. So with that, I hope this meeting actually puts forward some new thoughts, new ideas for our younger physicians to imbibe and move forward in the most positive manner.
Wonderful, sir. Thank you, sir. Thank you for this. Dr. A.K. Singh, sir. So, sir, your feedback about this meeting, sir.
Yeah, so it's wonderful. I can tell you that, thought leaders like Professor Peter Schwarz, when the IDF president comes and, bang on asking everyone to contribute, not in terms of, taking care of patients with diabetes, but look at the research, look at the prevention, look at the primordial prevention. I'm sure this kind of meeting will affect the younger generation's mind. And they would, I'm sure, would be thinking somewhere down the line that they should come forward and do, their bit to make life, good for people with diabetes. It's not only, in terms of research, but in terms of taking all the data put together in a holistic manner. So thank you very much for inviting me for this symposium. And as I said, thought leaders like Professor Misra, Dr. Sasank, and everyone, and I'm sure the generation across the country would be really enthused to do something. And when you get the top leaders like the president of International Diabetes Federation, they must be very enthused to do whatever in capacity they can. So thanks very much.
Wonderful, sir. As always, we enjoyed. We are more learned with your contributions in this discussion.
My pleasure.
So proud. Dr. Shashank Joshi, sir, if you're there, sir, your feedback about this meeting, sir. So I think it has been a memorable meeting for us. We are more learned. And in fact, thanks to Lupin for initiating this discussion. And we all know Lupin has stood the test of time since 1968, contributing to the global perspective. Now, Lupin is present across 6 continents, more than 100 countries, contributing immensely, taking the best of medicines to the best of the world perspective, diversity in terms of the attributes, the supply chain management, the vertical integration, the R&D contribution, and of course, the corporate social responsibility with the strong leadership reflections from the owner, late Dr. Deshbandhu Gupta, who initiated this organization. It's a long way to go from here. And this meeting would not have been possible with the initiation and the thought processes of Mr. Gagan Arora, who has been at the helm of one of the senior most leadership position at Lupin, driving this program, initiating and stimulating each one of us to do more and more such meetings so that the science cascades on the right direction. So I would like to thank each one of you, Dr. Peter Schwartz, for being there with us, thought leaders for being there with us. Before we close, I would like to hand over to the team, Anil, for the final vote of thanks. Thank you, everyone, for being there with us and making us more learned. Final vote of thanks now.
You're muted, Anil.
Yeah, Anil, kindly unmute. Yeah.
Yeah, thank you so much, Dr. Wadhwa. And my sincere thanks to all the panelists who present here, Dr. Anup, Dr. Peter, Dr. A.K. Singh, Dr. Shashank Joshi, also Dr. Bipin Sethi and Dr. Ganpati Bandpal for taking out your time on this Friday evening and giving it for this panel discussion. And I'm also sincerely thankful to all the attendees who are attending this meeting on this Friday evening. So we had a good number of registrations and logins, and thank you so much for taking out this time. As a Lupin, we are committed to do whatever we as an industry partner can do for this, providing better treatment for the type 2 diabetes and its management. So thank you so much, all the panelists and Dr. Wadhwa.
Thank you.
Thank you.
Thank you, everyone.
Good night from this side.
Good night.
Good night. Good night, everyone.
Good night. Thank you very much.
Honored, sir. Thank you, sir.
Yeah, thank you so much. So from here, I'm ending this meeting.
Thank you so much, Khushi, for coordinating from the Magica team side. It was not possible without you. Thank you again.